Hello again, it's Michael Mallinson of the Canadian Rheumatology Association, and this interview is with Dr. Vinod Chandran. So I'm just going to leave it up to Vinod to introduce himself and tell us about his role in rheumatology.
Hello again, I'm Vinod Chandran. I'm a rheumatologist at the University of Toronto, an assistant professor at the University of Toronto. I work at the University Health Network at the Toronto Western Hospital, and I'm an affiliate scientist at the Krembil Research Institute. My role, I am a rheumatologist, so I see patients with arthritis and related diseases, but my special interest is in a disease called psoriatic arthritis, which is one of the spondyloarthritis. This is a form of arthritis that affects patients with psoriasis. Now, psoriasis is a common skin condition, about 3% of the population have it, but a small percentage of these patients, say from 15 to 30%, get a form of inflammatory arthritis, which can be quite destructive. That's my area of interest and research.
And what drew you to that particular area? What's so fascinating to you about psoriatic arthritis?
So my interest, as I was finishing my training, was in identifying patients with inflammatory arthritis early. Now, one of the most common forms of inflammatory arthritis is rheumatoid arthritis. The other one, of course, is ankylosing spondylitis. The trouble of identifying patients early is that you have to look at the general population to identify risk factors for this. But if you want to study early mechanisms of disease, psoriatic arthritis is a disease because it happens in patients with psoriasis. Almost 90% of the time, the skin disease happens first, and then the arthritis. So you have a captive population that you can study more closely to see why some develop arthritis, some do not. And so my interest from a research perspective was to look at this group of patients who have, who are at risk of arthritis and then develop it, so I can identify the early mechanisms of having that and hopefully identify it early and prevent it, as opposed to looking at a much broader population where it's even more difficult. And of course, the disease psoriatic arthritis affects the skin, the joints, and sometimes other organs like the bowel and the eyes. And so patients have a lot of, very poor quality of life, higher mortality, and the disease is not that well recognized. It's not high up on the radar of many agencies, and I thought focusing on this disease would help have a bigger impact, and that's why I focus, both from a clinical perspective as well as my research perspective, on psoriatic arthritis and related diseases.
That's actually very interesting what you said about the prevalence of it. If 3% of the population have psoriasis and about 30% of them have psoriatic arthritis, that's quite a high prevalence for, in some ways, compared with ankylosing spondylitis and rheumatoid arthritis. It's getting up there.
Right. And so these are numbers based on your presumption that small studies that show, relatively small studies that show 30% of patients with psoriasis who come to psoriasis clinics, so maybe the more severe end of the spectrum have the disease. If you go back to population studies, it's about 15%. So anywhere between 15 to 30%, it's still a huge number, especially since the prevalence of psoriasis is about 3%, and over the last few decades, it's been shown that the prevalence is actually increasing, and it's most likely due to environmental reasons. Comorbidities are important. Obesity is a risk factor for psoriasis, and since obesity prevalence is going up in say North America, I think that's one of the reasons that's driving the disease. And so it's not just the skin and joints, but it's also the comorbidities, obesity, metabolic syndrome that drive the disease. And so for a holistic approach, we need to look at all these aspects and take care of the patient as a whole. So that's my focus.
Oh, interesting. Yeah. Here's a dumb question. Is psoriasis itself a form of arthritis? Or what's the line between psoriasis and psoriatic arthritis?
Right. So psoriasis is an inflammatory immune-mediated disease. It manifests as skin rashes mostly on the extensor aspects of your extremities, the trunk, on your scalp, and it used to be looked at as a skin disease, but we know as we look carefully at patients with psoriasis that it's not just the skin, other joints, the bowel, the eyes, cardiovascular disease, all that seem to be at much higher prevalence in patients with psoriasis, and some of the excessive inflammation in the skin or other areas drives the disease. So it's not just a skin disease, it's much more, it involves a number of internal organs also, and one of the less recognized problems, of course, is the severe mental health issues that patients with psoriasis have. So it's a systemic disease. It affects the skin and other organs that I mentioned. So there's an interesting study by one of my colleagues at the NIH where they've scanned patients with moderate to severe psoriasis who apparently had no other problems except for the skin disease. And when you do such an inflammatory scan, you see that the joints light up, the liver lights up, the aorta lights up. So there is inflammation going to subclinical. And some of them progress to develop clinical disease, maybe, psoriatic arthritis that we see in our clinic when they come with joint pain, or liver dysfunction and cirrhosis, so-called cirrhosis not related to hepatitis or alcohol, which is related to metabolic syndrome, which is, I guess, nowadays the most common cause of cirrhosis in North America, because infections are not that common and can be treated because of the drugs that are available now. And then cardiovascular disease when they present with, say, an MI or stroke. So that's the clinical, but there's a lot of things that are happening underneath, and so the iceberg phenomenon is a big problem, or is now recognized in patients with psoriasis. And so we're looking at deeper phenotyping, identifying those who are, so we can prevent that from clinical disease from happening, and therefore improve quality of life, bring down the costs, and that's where our research is going, identifying biomarkers for these conditions.
Oh, I see, yeah. I understand about 50% of patients with psoriatic arthritis have spinal involvement, like ankylosing spondylitis as well. Is that about right, that figure?
Yeah, it depends on when you look at it. So some patients present with just the spinal disease with psoriasis, and that would be without any other manifestations outside the spine. So no arthritis in the hands and feet, or they present with back pain and stiffness and psoriasis. That would be about 2% of the patients. Most patients present with peripheral arthritis, and when they come for the first clinical evaluation, about 30% of them have spinal involvement. And as years go by, our own data show that about 50% have some form of spinal involvement. Compared to ankylosing spondylitis, it is recognized that spinal involvement is not that severe, although some patients can have really severe spinal involvement. And although many of the features of the spinal disease are similar to what happens in ankylosing spondylitis, with bilateral symmetrical sacroiliitis and syndesmophytes, some patients have, a large proportion have spinal involvement that is different from ANKSPON from when you look at the X-rays. So they could have unilateral sacroiliitis, they could have syndesmophytes, or involvement of the neck rather than the lower spine. They could have no sacroiliitis at all, but spinal involvement in the neck. The syndesmophytes that we see in ANKSPON are what we call classic syndesmophytes. On X-rays, they're seen as thin bridges between the vertebral bones, whereas in psoriatic arthritis, you can have what we call non-classical or paramarginal syndesmophytes, which the doctors would recognize as being different, and it looks like a jug handle, jug handle on the bone rather than a thin spine. So there are differences, there are similarities, but importantly, recognizing that a patient with psoriatic arthritis has spinal involvement is important, because those patients tend to have much more severe disease, so they have much more severe peripheral arthritis, more destructive peripheral arthritis, and so that's the manifestation of severity. So that's why we always evaluate for back involvement. In patients with back involvement, we use that in our treatment algorithm to treat them probably more aggressively to prevent long-term complications.
Oh, I see. That's fascinating. And in ankylosing spondylitis, there's supposedly a gender difference. Personally, I think it's probably one-on-one these days, but is there a gender difference in PSA?
Not really. It's almost equal male and female. There's a slight male preponderance. Some studies say 55 to 45, 52 to 48, but I would say essentially it's 50-50 from if you look at it from the psoriasis point.
Yeah. What sort of research are you involved in at the moment? Can you tell us, about one or two projects that are particularly interesting for you?
Right. So I'm a translational researcher, and I'm looking at. I see patients who I know, and I'm involved with the community, both with the patients and with researchers and clinicians. And so, along with my advisory committee of patients that I have in my research program, the unmet needs are upfront. So the unmet needs, from my understanding, are early diagnosis, appropriate evaluation of disease activity, and then appropriate treatment. So my focus of research are directed to these. And so, like I mentioned earlier, my focus is on identifying patients with psoriasis who are at higher risk of developing psoriatic arthritis. But also, we recognize that because a lot of patients are seen by dermatologists, they are within the medical community, but the arthritis is not evaluated. And so there are studies from North America and Europe that have shown that up to 30% of patients with psoriasis have psoriatic arthritis when they are in these clinics, and a large proportion of them are unrecognized. So when a dermatologist goes to a psoriasis clinic and evaluates patients there, he identifies psoriatic arthritis, which was otherwise unrecognized. And is that a problem? It is, because we know from data from our center as well as from Dublin that the more delay there is in making a diagnosis, you have worse outcomes. So early diagnosis is important. Since there is nothing at the moment that we can do to prevent the arthritis from happening, at least identifying patients in the dermatology clinics with arthritis would help in better management. So one of the major projects that I'm currently doing is to identify biomarkers that are, a blood marker, because that's a blood test is easily transferable and translatable into a test that you can do in the clinic. So I'm looking at blood markers, mostly proteins, and beginning to look at metabolites that can identify patients who already have arthritis or are high risk of developing arthritis, so that they can be identified, then formally diagnosed by appropriate referral to a rheumatologist, and then appropriately treated. So that's one major project. The other project is focused on patients who already have arthritis. The problem with assessing disease activity, we assess disease activity by talking to our patients, identifying what symptoms they have, the degree of stiffness, some degree of pain, then doing a physical exam, looking at swollen joints, tender joints, presence of sausage digits, so-called dactylitis, pressing on the enthesis to figure out there's tenderness there. We also we look at imaging, say ultrasound or MRI to kind of judge the degree of inflammation, and then come up with an impression on how active the disease is. As you can, at the moment, blood tests like ESR and CRP that is commonly available to look for inflammation are not very good. Most patients, I would say majority of patients with active disease have normal, regular, the usual acute phase reactants. So that's a challenge, and as I've described the various steps that we take to make a disease activity assessment, is problematic, right? Because it takes a lot of time, and time is not a currency that people have.
Yeah.
Clinics are busy, doctors don't have that much time. They at max have, in most clinics, 15-20 minutes, where when you do have a lot of complex assessments to do, there is a problem. So my vision is that if we have a panel of markers, I think because it's a complex disease, 4 to 8 of them would probably ultimately be in a panel, and we can do that test to indicate that the disease is active or not. Assessment of disease activity much more reliable, and maybe that would help us treat our patients better, because then we know this is truly active and we just need a change in treatment. And some are not active, and so change in treatment is not really required. So that's another area of interest, of focus, of developing a disease activity biomarker panel. And the third one is I'm also working to, one of the problems with patients with psoriasis is there are biologic therapies available, but a lot of them still require topical therapies. And steroid therapies are only topical therapies that are now available, and they thin the skin. It's a problem long term. So developing newer therapies that could improve psoriasis, topical agents. It's a low-hanging fruit. We have biomarkers that we know are overexpressed in the skin. So if we can inhibit that by topical therapy with an appropriate vehicle, that will help psoriasis in a lot of patients. So that's another area of focus. So,
fascinating. Thank you very much, and hope you have positive outcomes to all those research projects. Are there any questions?
There are indeed, actually. This is a hot topic and a hot interviewee over there. We have two questions, I think, right off the top that we have time for. The first one is, so for us out here, in the public, what are some of the most common early symptoms of, I guess, both psoriasis, now learning it's an autoimmune disease, but also psoriatic arthritis? So what are some of the first signs and symptoms?
So psoriasis begins as a rash on your skin. It's usually present on the extensor aspects of your arm, so back of your elbow, front of your knee. That's the most typical site, sometimes the back of your scalp. And because it's a skin disease, unless it's in a hidden area, it's easily recognizable. And so most patients can recognize it early. Family history is strong, so there's usually about half of patients have somebody with the family, either first degree relatives or second degree that have the condition, and so that helps in the diagnosis. And for psoriatic arthritis, one of the early symptoms would be presence of nail disease, so that should be looked at. And
what is that? Deformity of the nails?
There will be pitting and lifting of the nails. With yellowness of the nails. That's an important sign that maybe something's happening once somebody with just psoriasis starts developing these nail conditions, because that's strongly associated with the arthritis. And other early symptoms would be joint pains, hands or feet, especially the lower limb would be important. Pain around the knee, if not in the knee, as well as pain on the heels, all indicating what we call enthesitis, or inflammation where the tendons or ligaments attach to bone.
Great. And the last question here is depression more common in psoriatic arthritis than in the other types of autoimmune arthritis diseases that you've mentioned?
Depression is a common comorbidity in almost all, and one can imagine why that's common. It's also a common problem in psoriasis, and in our own studies we've shown that comparing psoriasis to psoriatic arthritis, so comparing just skin disease with skin and joint disease, depression seems to be much higher. I've not personally done a comparative study looking at RA versus psoriatic or psoriatic arthritis or ankylosing spondylitis. We could easily do that study, but it's still very highly prevalent. It's a big problem in lupus. It could be a manifestation of central nervous system involvement in lupus, and also in rheumatoid. So I think it's a common problem, less recognized. Patients are not asked. Maybe the physicians are afraid of asking, but that's the thing that we need to do.
We've heard about that this morning, yes.
Yes.
Yes. Okay, wonderful. If there's no more questions, I want to say thank you very much, Vinod. That was really informative, and thank you for coming in.
Thank you, Michael. It was great.
Good.